Now we will switch topics from fluids to talk about pressors. You have probably noticed that I've placed pressors in quotation marks. This is to bring attention to the fact that not every medication in the general category of quote pressors actually increases blood pressure. There are two major types of pressor. First, there are vasopressors. These drugs act to increase SVR and subsequently increase blood pressure. Then there are inotropes. These drugs act to increase cardiac output through increased contractility. For various reasons, blood pressure may be either increased or decreased in response. Use of vasopressors and inotropes is very complicated, and this lecture will provide only the basics of this complexity. The single largest reason the pharmacology and use of these drugs is so complicated is because a given drug may have an effect on multiple different receptor types, and the receptors on which it acts may be dose dependent. In addition, any given drug may affect systemic blood pressure through both its direct actions as well as its indirect reflex actions. Here's a table of some common vasopressors and inotropes. I understand the resolution of this video may prevent the table from being legible, but don't worry. While in some ways this table is an oversimplification, it still remains far too cumbersome to memorize or have available at your fingertips in an emergent situation. Luckily, it can be drastically simplified without losing too much critical and clinically relevant detail. Here is the ultra-simplified version. On the left are the 7 most commonly used vasopressors and inotropes, and we can see what effect each has on the SVR and cardiac output relative to the others. On one extreme, phenylephrine is a pure alpha agonist, and therefore a pure vasoconstricting agent, with a direct action of increasing SVR and the indirect reflex action of lowering cardiac output. On the other extreme, milrinone is a phosphodiesterase inhibitor that directly increases contractility and directly vasodilates. The other drugs pretty much line up as so. Some might point out that vasopressor may be equivalent to phenylephrine in terms of its effects on SVR and cardiac output. As I've already said, this is an extreme simplification, but unless you are planning on becoming an intensivist, it is probably sufficient enough understanding of the basic hemodynamic effects of these drugs for the majority of patients you encounter. The most important side effect of pressors, of which you should be aware, is arrhythmias, the most significant of which is ventricular tachycardia. Different pressors carry different arrhythmogenic risk. Going through the list, both phenylephrine and vasopressin carry no direct risk of arrhythmias, though if excessive unopposed vasoconstriction results in myocardial ischemia, there may be some degree of indirect risk. The risk from norepinephrine is modest, while that of epinephrine is significantly more. Risk from dopamine exhibits some dose dependence, which may be more than seen with other pressors. Risk from dobutamine is modest. Whether milrinone leads to arrhythmias at all is debated, but the risk is modest at best. So in summary, the greatest risk of VT comes with either epinephrine or high-dose dopamine. Another aspect of pressors of which you should be aware is their serum half-lives. The values here represent averages, and the half-lives are probably longest in the sickest individuals due to the most deranged metabolic pathways and organ dysfunction. First, phenylephrine is 15 to 30 minutes. Vasopressin is 10 to 20 minutes. Norepinephrine has been reported anywhere from 2 to 7 minutes. Epinephrine, dopamine, and dobutamine are all about 2 minutes, so a very short duration of action. Finally, milrinone's half-life is very long, about 2.5 hours. There are a couple of reasons to be familiar with these values. First, it's easy to understand why the only drug commonly given as a bolus outside of a cardiac arrest is phenylephrine. The other drugs, with the exception of milrinone, are too short-acting to make sense. Also, one can appreciate how important it is for medical staff to keep an eye on the medication bags to ensure that these bags don't run out. Within minutes of the med running out, the patient's blood pressure will start to crash. Finally, the very long half-life of milrinone explains its limited usefulness in shock, It can take hours to reach steady state, and if you start milrinone and the patient responds badly to it, you've got to wait hours for it to wear off. So now, how do we go about choosing which pressor to use in a specific circumstance? As a general rule, the choice of pressor should be guided by which physiologic parameters are responsible for the shock. For example, in a patient with pure distributive shock, where the primary hemodynamic derangement is low SVR, a pure vasoconstrictor would be appropriate. However, in cardiogenic shock, where the primary derangement is low contractility, a pure vasoconstrictor would be contraindicated. Let's look at some more examples. What's the best pressor to use in septic shock? Either phenylephrine or norepinephrine. Although vasopressin is a pure vasoconstrictor and would seem to be appropriate in this circumstance, in practice most clinicians prefer to reserve it along with either dopamine or epinephrine for septic shock refractory to another agent. What about cardiogenic shock? Usually dobutamine and or dopamine. The common practice is to use dobutamine and to add low to moderate dose dopamine as necessary to maintain adequate blood pressure, since blood pressure can be minimally affected or even lowered when dobutamine is used as a single agent. What about mixed cardiogenic and septic shock? Dopamine is the preferred agent as it has both inotropic and vasoconstricting properties. What about hypovolemic shock? Aha, this one is a trick. The deranged parameter here is lack of intravascular volume. Therefore, no pressor is appropriate. Actually, however, a more accurate statement is that no pressor is appropriate for prolonged use. Occasionally, a pressor might be used in hypovolemic shock as a very temporary measure to achieve life-sustaining perfusion pressure while more definitive IV access is obtained and fluids infused. In practice, phenylephrine as intermittent boluses tends to be used in this circumstance most frequently, though as SVR is already extremely elevated as part of the body's natural reflex against low blood pressure, you can begin to run into serious problems with digit and limb ischemia. Lastly, shock of unknown etiology. Dopamine is most frequently used here since it has a good balance between inotropic and vasopressor effect, though norepinephrine is probably an acceptable alternative. Although epinephrine would seem to be an appropriate choice in this circumstance, along with mixed cardiogenic and septic shock, epinephrine is usually reserved as a second-line or even third-line pressor due to the combination of its high arrhythmogenic potential and mesenteric ischemia that it can contribute to. The astute viewer might note here that phenylephrine above has been given an asterisk and dopamine has a little cross, indicating I probably have something more to say about these two pressors in particular. First, a word about phenylephrine. In 2008, the Surviving Sepsis Campaign released new guidelines in which they stated, "We recommend either norepinephrine or dopamine as the first choice vasopressor agent to correct hypotension in septic shock." They further stated, "We suggest that epinephrine, phenylephrine, or vasopressin should not be administered as the initial vasopressor in septic shock." Well, why do they state this? Doesn't this contradict what I've just talked about? The reason for these recommendations appears to be the observation that a significant minority of patients with septic shock develop a de novo cardiomyopathy that is oftentimes unrecognized. In other words, many patients who are thought to have pure distributive shock actually have mixed distributive and cardiogenic shock. Thus, a pure vasoconstrictor like phenylephrine may not be a good idea. What is the evidence for these statements? The first statement is given a grade 1C. For those of you not familiar with guideline grading system, the number refers to how strongly the consensus was about a given recommendation, and the letter refers to how strong the evidence was supporting the recommendation. A grade 1C recommendation means that everyone in attendance thought it was a good idea, but that there was no evidence to support this assertion. The second statement is given a grade 2C. This means there was disagreement as to whether it should be a recommendation at all, and there was no evidence about it one way or another. In other words, they really don't know. I think the point the Surviving Sepsis campaign is trying to make is a good one, but if you feel quite confident that a given patient in front of you has pure distributive shock and that their cardiac function is completely normal, using phenylephrine as a first-line agent is perfectly acceptable. Now, a word about dopamine. In 2010, a multi-center RCT was published in the New England Journal of Medicine in which 1,600 patients with shock of any cause were randomized to dopamine versus norepinephrine. There were virtually no exclusion criteria. The primary outcome measure was all-cause mortality. Here's what was found. There was no statistically significant difference in survival between the two groups, though dopamine was associated with more arrhythmias. The big news from the study came from the subgroup analysis, where mortality was examined based on the shock subtype. As you can see, patients specifically with cardiogenic shock did better if they received norepinephrine. This is in contrast to what seems to make the most physiologic sense, and is in contrast to the American College of Cardiology guidelines on the management of cardiogenic shock complicating acute MI, which recommends dopamine as the first choice agent. Unfortunately, the study had a couple of methodologic flaws which might explain away this finding. However, it is one of the best and only head-to-head RCTs between two pressors in the literature, which calls into question how much we really understand about how these drugs work. It's certainly possible that if I give this lecture again in 5 or 10 years, the recommendations I provide may be completely different. Finally, here's a last slide which summarizes our treatment principles for the 4 major shock subtypes. For hypovolemic shock, IV fluids are definitely indicated, but not vasopressors or inotropes, unless using a vasopressor for a very short duration of time while fluids are infusing. Other etiology-specific considerations include blood for hemorrhage and PPI and/or octreotide for an upper GI bleed, depending on its origin. For distributive shock, IV fluids and vasopressors are definitely indicated. Inotropes may or may not be indicated depending on the presence of concurrent myocardial dysfunction. Other considerations include, but are obviously not limited to, giving antibiotics and/or steroids. For cardiogenic shock, inotropes should be your major treatment modality. You should also consider diuretics, vasodilators, and possibly even an intra-aortic balloon pump. If the shock is from an acute MI, the patient should be taken emergently to the cath lab for reperfusion, and if due to an arrhythmia, the underlying arrhythmia should be the primary problem to address. Lastly, for obstructive shock, IV fluids, vasopressors, and inotropes can all be tried in various circumstances and in various combinations, but all of these are temporizing measures at best, as the patient's shock is unlikely to improve until the underlying anatomic obstruction of blood flow is dealt with by either thrombolysis in the case of massive PE, pericardiocentesis and cardiac tamponade, and a chest tube or simple thoracentesis in the setting of a tension pneumothorax. I hope you have found this lecture informative and useful. Once again, this has been Eric Strong of the Palo Alto Veterans Hospital and Stanford University.